talking about the secondary assessment. So I've got my patient medical assessment document up on screen here. So just to kind of recap what we've already covered, first section is going to be scene size up. And within the scene size up, we've got our scene safety, we've got our BSI, MOI, NOI, number of patients, additional resources, and C-spine precautions. And then we move into our primary assessment, going through our general impression, our level of consciousness, our chief complaint, airway, breathing, circulation, and our determining transport priority. So if I were to go through this like I would an actual scenario or an actual call, I would start by going, okay, I've got my BSI on. Is my scene safe? Based on my dispatch information, we'll say I was dispatched out to a 65-year-old male with chest pain. That is a nature of illness. It's chest pain. Number of patients at this time is 1. We will need a transporting ambulance service and potentially our advanced life support or those paramedic level services for our additional resources, and no scene spine precautions at this point. Moving on to the primary assessment, our general impression of the patient walking up, we notice that our patient is pale. They've got the Levine sign. It looks like they maybe have been throwing up. But they are alert. They're looking at us. They noticed us walk into the room. So, hi, my name is Mallory. I work for Southwest Tech Ambulance. What's going on today? Oh my gosh, I've got horrible chest pain. I think I'm dying. Well, chest pain is the chief complaint. The airway is open because they were talking to us. At this point, we have no reason to think that it won't stay open, right? We don't think it's going to close at this point. Breathing, we'll take a look at that rate, rhythm, and quality of the respirations. We'll say that the rate appears to be in a normal range. Usually you can tell if they're extreme at this point, right? Really fast or really slow. We'll say that the rhythm of the breathing is normal, it's steady. And then the quality, we'll say that's normal as well. They don't have any noisy breathing, no wheezing, no gurgly noises, nothing like that. Circulation, is there any blood? We'll say that we don't see any on this patient. They're pale, that's their skin condition. They do, in fact, have a pulse. At this point, we're more so worried about how strong is the pulse. Is it super weak? Is it super fast, super slow? What's that quality like? Whoops, just edited that. There we go. What's that quality like? And then based on our findings, we're going to determine the priority of our patient. Are we going lights and sirens, that high priority, or are we going low priority, nice and slow, right? If we are going, actually, if you're working for a transporting service, that's when you decide fast or slow. If you're not working for a transporting service, this is where you would call in your radio report to the transporting service and say, hey, we've got a 65-year-old male patient here, alert and oriented ×4, complaining of chest pain. Currently, breathing rate is 20 and pulse is strong at the wrist, right? No vital signs yet. And then you move on to your secondary assessment. All right, so let's go ahead and we'll kind of scroll down here to the secondary assessment. Secondary assessment, this is after we have already dealt with all of the life threats, right? We've got a patient that, stable or unstable, they're not going to die within the next 2 minutes, right? Like we've got some time to ask some questions at this point because we fixed all of the airway, breathing, and circulation problems. So we start asking things like medical history, history kind of leading up or about this specific incidents. And then we look at our vital signs as well, and we start getting those vital signs. Vital sign chapter was chapter 13. We did that last week. We went through our 6 normal vital signs and then our 2 bonus vital signs, the temperature and blood sugar. And then reassessment is the last category for our medical assessment. So I'm going to flip over here to my PowerPoint slides. We'll get that up and going. So secondary assessment, kind of already talked about that. Again, we've got our medical patients, our trauma patients, and our patients that are both or unknown. In our trauma assessment, we always want to be doing a physical exam. We'll get hands-on with our patient kind of right away doing what we call a rapid trauma assessment. We also do a detailed trauma assessment as well. And those are a little bit different. Again, we'll go into those more in depth with our trauma class. So don't forget about these things, but don't worry about them too much. We're not going to get tested on them yet. Okay. Those trauma. The other thing is looking at past medical history and history for the patient. So there is a difference between a sign and a symptom. A sign is something that we see, like they're pale, that's a sign. And a symptom is something that the patient tells you, like chest pain. We can't see chest pain, they have to tell us that they have it. And then we're always going to continually reassess our patient. Things change, right? So just because we did it once doesn't mean that it stayed absolutely the same. So our responsive patients can hopefully answer questions, medical questions for us. Of course, that's going to depend on the patient's mental ability, right? So they might be a dementia patient and not able to answer a lot of those personal medical patient like questions. Or maybe they're really young. Maybe we've got a 5-year-old and they're not gonna know a whole lot of answers for you, right? So kind of base it on the patient's age a little bit, but hopefully they're able to answer history questions. Unresponsive patients can't, of course, but there are different ways that we can get patient history. We talked about that. We always want to go to the patient first when we're asking these history questions. Obviously within reason, right? We're not going to just start talking to a 6-year-old asking them, or not 6-year-old, 6-month-old, asking them questions about their patient, their history, their medical history. We're going to probably talk to the family first, but you get the idea, right? We want to go to the patient first. And then if they are not able to tell us, we'll talk to family, bystanders, caregivers, to get good, adequate information. And then we do want to base some questions on the chief complaint. So we've got our sample mnemonic that gives us a general kind of starting point. And then we want to ask additional questions that have to do with that chief complaint. It's always better to ask open-ended questions to try and get the patient telling us kind of a story as opposed to yes or no's. But there is a benefit to closed-ended questions as well, and we'll get into that. Actually, I'm going to go back just slightly. So I wish I was able to share my screen a little bit better. I have no idea how old everybody is in this class, right? I noticed a lot of you were in college based on your introductory posts. So I'm guessing you're, in your 20s. So most of you probably know about this feature already, but I do like to tell all of my classes this. I, as a medical provider, have used this in the field and it's come in handy. And I like to just kind of spread the word to make sure everybody knows about it. But your phone, if it's a smartphone, whether or not it's a Samsung or an iPhone, it doesn't matter. If you go to the screen, that's like your emergency screen, right? Where you don't have to unlock the phone, you just type in 911 or whatever. If you go to that screen, at the very bottom of the screen, there should be a red kind of button that says medical ID. If your patient has this set up on their phone already, you can click that medical ID and then it will tell you, the provider, medical information about them. So for mine, for example, it says my name, how old I am, I'm an organ donor, it says the medications that I'm on, it says allergies, and then it's got my emergency contacts as well. It's got any conditions or a spot for any conditions, and then additional information like height, weight, blood type. I think there's just a general place for comments as well, so they can type in information that's pertinent for them. This is something, like I said, as a medical provider, I have used this on patients before where we have patients that are unresponsive, but they've got their phones on them. So we can kind of look this up. Because every phone owner has to set this up specifically, it is available for us to use. It's not like an invasion of privacy or anything like that because they chose to set it up for this purpose. So it is something that I would recommend you all set up if you haven't already, or remember to update it as things change, and then start spreading the word as well. It's you never know when something's going to happen, young or old, something might happen medically, and they might not be able to tell the provider that, hey, they take blood thinners or whatever it is, right? So I do recommend that you guys get that set up. All right, next one. We want to make sure that we're asking those pertinent questions for the patient. I think we're going to dive deeper into that in just a minute here too. I want to go with the slides as much as possible, keep me on track. So we're going to perform a physical exam pertinent to the chief complaint. With our medical patients, this is a little bit different, right? We don't need to, if they've got chest pain, we don't need to strip them completely naked, right, to determine whether or not that's true. But when you think about chest pain, what are some differential diagnoses that go through your head? A differential diagnosis is kind of a working theory. It's another way of putting it. Based on what we're seeing, what do we think this is? That working field diagnosis. So chest pain. What comes to mind immediately? Probably something to do with the heart, right? Probably a heart attack, something like that, right? Um, and maybe, right? But it could also be something like, hey, they just lifted yesterday. They've been trying to get a PR, and maybe they tore their pec muscle. There's also, what is it? Women around the age of 18 to 30, for whatever reason, and I'd love to learn this a little bit more in depth, they have something called a precordial catch, which is basically a muscular chest pain that happens, but it feels horrible. It's like crushing, sharp chest pain. And it's completely benign, but they get it every once in a while. So we want to start thinking about kind of the different reasons that might be causing this. So when we're doing a physical exam, if you push on the patient's chest, just up by their collarbones, if you push on their chest and it hurts more while you're pushing, it's not cardiac, it's muscular. So that would be an example of the type of physical exam that we would do. Another chest pain one that we get called for is patients that have been coughing a lot will get some muscular chest pain as well. We want to get a set of vital signs. Our baseline set involves those 6 vital signs and 2 bonus vital signs. Sorry, I'm jumping around just a little bit here because I've gone off script a little bit, so I don't want to repeat myself too much. When we're talking to kids and dealing with kids, of course, it is so incredibly dependent on the child themselves, but also the age of the child. There are certain kids that it is crazy how outgoing they are, and they just want to talk to everybody, you included. And then there's other kids that don't want strangers even looking at them, let alone talking to them, right? So you kind of have to gauge your conversations depending on the child and also their ability to talk to you, right? We don't want to completely ignore them, right? Obviously, it's not a good option. We still want to talk to them. Use language that they can understand, right? Instead of saying, do you have hypertension? We'll, ask it in plain English. Use that simple language. Does anything hurt? Can you point to where it's at? Did you fall down? Did you, something like that, right? And then of course gather information from caregivers as well. I find that as a full-time service, working for a full-time service, I've got a specific uniform that I'm required to wear. I know a lot of volunteer services don't have anything like that, but on my uniform, I always have very specific like children's things. So on the back of my ID card, I've got a little Finding Nemo sticker. I love Finding Nemo, so it's super easy to talk to kids about it because I like it too. And then I've got a lapel and I've got lapel pins. So for the different seasons, I'll wear a different pin. So like I've got an ice cream truck and I've got Winnie the Pooh and I've got Christmas trees and so I'll change them out. So if I do happen to have a patient that is younger, I can talk to them about it. It's an easy thing to start conversations. Another nice thing, if you do have the ability to keep up on what children's TV show is popular at the moment, that's always a good one too. So I guess I'm a little out of date, but I feel like Bluey at least was super popular. I'm not sure if it's still the number one, but it was really popular. So knowing at least a few of the characters' names or a general idea of what it's about is a good way to get them talking or a little bit more comfortable with you. Unresponsive patients, we still want to do that baseline physical exam, vital signs, and then, of course, talking to those relatives and bystanders about getting information. You can also look at, like, some people have tattoos on their forearms that'll say things like diabetic, or DNR isn't a valid tattoo. That's not a legal tattoo, but most people, if they get diabetic tattooed on them, it means that they're a diabetic, right? Also like bracelets or necklaces, Apple Watches as well. And I don't know like the Samsung equivalent, but Apple Watches have that medical ID feature as well if you get to that emergency screen. So you can check their Apple Watch, and that does work without their phone. So if they were, say, working out and didn't have their phone on them, just their Apple Watch, you can still get to that medical ID. This is your trauma stuff, so I'm just skipping over that. Vital signs we already talked about. Consider ALS. So ALS stands for advanced level. Why am I blanking on this? I'm blanking on what the S stands for, but it's your advanced life support personnel. So this is like your paramedics. I want to say advanced EMT is included in that as well, but they're the ones that you're going to call if you need like IVs or additional medications given to the patient. So obtaining histories, we want to know things like patient's name, what happened, did you see anything, if we're asking bystanders, did the patient complain of anything before it happened, do you know if they take any medications or have any medical problems. We're going to look for evidence of spinal problems, that things that might suggest that there's an injury to the spinal cord or column. Medical history, we can talk to the family, bystanders, patient, of course. A lot of patients will have either a list of their medications or the medications kind of like, I don't know why they're always in the kitchen, but a lot of people keep their medications in their kitchen. If they're sitting on the countertop, we can go over and take a look at those. I mean, if you don't feel comfortable just going and doing that, you can ask, of course, and taking a look at those medications. This course does not necessarily give you all of the information about all of the common medications that are out there. I'll mention a few different times that you might start to catch on to, but throughout just working in EMS, you'll start to see medications that are prescribed often, and you'll get used to them. Like metoprolol is prescribed pretty often, and that's for blood pressure medication. So if you see that, you know that your patient has high blood pressure, right? Warfarin is a blood thinner. So if you see that, they probably have some sort of cardiac health. Also, if they just fell, we need to be really concerned that they're, hemorrhaging, right? I'm going to skip over secondary assessment with trauma patients. DCAT BTLS, that's something in a few weeks I'm going to say, hey, do you guys remember what DCAT BTLS means? And you're all going to stare at me like I'm crazy. This is what DCAT BTLS means. It is something that we will talk about more in trauma, but if you want to start studying that now, that would be a good idea, right along with OPQRST and sample. Placing a C-collar, we won't talk about for a little bit. Examination of the patient, we'll talk about for a little bit. Rapid assessment, we're not doing that. Nope, not doing that either. General principles, always tell the patient what you're going to do. If you're going to feel their chest because they've got chest pain and you want to make sure that it's not muscular, tell them or ask them like, hey, is it all right if I, touch your chest right here? Just let me know if it hurts. Make eye contact. I mean, don't be creepy about it, right? But, make eye contact with your patient. Yeah. One thing that we deal with on pretty much every single patient as anxiety, whether they've got a diagnosed history of anxiety or what it may just be like an acute thing that's happening because we're called. All of our patients have some level of anxiety. So doing things like explaining to them what's happening and what we're going to do and what our plan is moving forward is really helpful. And we'll talk about this a little bit when we actually get hands-on with like our cot and our stair chair. But there's little things that we can do that just help ease people's anxiety so much. And it also kind of makes you look awesome as a provider when you do that. Providers that are confident talk to their patients. Um, if you have no idea what you're doing and all you're doing is like thinking in your head, oh my God, what do I need to do? What do I need to do? What do I need to do? Um, Oftentimes you don't talk to your patients, right? So even if you're not confident and you're talking to your patient, it'll seem like you're confident in what you're doing. Uh, Tilt physical exam. Okay, so I don't know if I missed the slides on sample and OPQRST or what, but I definitely want to talk about those as well. So I'm going to pull this back up, this one back up. So sample is a mnemonic. So signs and symptoms is the first one. So what are their signs and symptoms? At this point, you probably already know what they are and you don't need to really ask again. Say it was chest pain and they're super pale, they've been vomiting, that type of thing. That's my signs and symptoms. You can ask questions like, okay, I think this is cardiac, so I'm gonna say like, do you feel dizzy at all? Do you have any additional things you want to tell me? Just to check that off and make sure we're doing a thorough assessment. Allergies, super straightforward. What are you allergic to? Medications, again, what medications are you taking? A good follow-up for that is what are you taking them for? Especially if you don't know what those specific medications are. Knowing what they're for is really good. And then that kind of ties us into this past medical history. Even though they might not be taking a medication for it, they may have some medical history that's important for this. So we'll say, going with the chest pain, past medical history, they had a heart attack 5 years ago. Another really good follow-up is, does this feel the same as it did 5 years ago? Also, like, what treatments did you undergo afterwards? Do you have, a stent placed or open heart surgery or anything like that? So you just want to dive a little bit deeper. These are really good starting points, but we want to ask those follow-up questions as well. Last oral intake, what did you eat or drink last? This is really important, not only because sometimes our patients need to go to surgery and it's important to know what they ate or drink last, but also things like they're having an allergic reaction. Knowing what they ate or drink last can be helpful in determining what caused the allergic reaction. Events, how did this come about or how did this happen? This is the events leading up to the reason to call us. So I've got chest pain or my patient has chest pain. What were you doing when the chest pain started? Like, oh, I was, mowing the lawn while it's like 90 degrees outside. It's probable that, the heat kind of started all of this. OPQRST is this next little segment here. The first one is onset. Now, onset and events, and then the T for time, kind of blend into each other a little bit. When we think of those words, they blend. However, they do mean three very different things when we're looking at our assessment. So events, what happened leading up to this? Onset is, was it a slow onset or a rapid onset? So when the chest pain started, did it just hit? Like all of a sudden it was just there? Or was it something where, you woke up this morning and really just weren't feeling great and, it just kind of felt crummy all throughout the day. And then, you maybe noticed that there was a twinge there at breakfast, but just kind of ignored it because, aches and pains. And then it hit, was there a buildup to this, that slow onset? Provocation, does anything make it better or worse? Oftentimes with chest pain, reducing the amount of activity that they're doing, like sitting down, resting, makes it better. Quality, what does it feel like? With this, patients can get a little confused, like, what the heck do you mean? What does it feel like? It hurts. But knowing like sharp, dull, heavy, crushing, those types of adjectives can really help narrow down what's causing this pain. Radiation is, does the discomfort move anywhere? So with chest pain, super textbook one is that it's going to go to the jaw or the left arm. I hate to say it, when it comes to radiating pain, women tend to be a little weird. Um, we are very not textbook when it comes to this. I had a patient that was actively having a heart attack, and her only symptom was that she had really bad wrist pain. So we got called there thinking that it was going to be a broken wrist. Found out that like there really wasn't a mechanism of injury, and it was like, well, like you're in your 50s, you said you have like a history of hypertension, like we'll just see if you're having a heart attack. Might as well, we're here, right? And it ended up she was actively having one. So keep in mind, radiation is incredibly important, but women can be a little bit weird when it comes to where the pain goes. Severity, can you rate your pain on a scale of 0 to 10, 10 being the worst? You can also use the Wong-Baker Faces scale. So you guys have seen those, I'm sure, in pretty much every doctor's office. They've got those pictures of like a really happy yellow smile face all the way to like a really purple, sad smiley face. Sad smiley face? Frowny face. And then time. What time did this happen? So time, we want to know exactly, like, this happened 20 minutes ago. Okay, that was at 6 p.m. Or whatever time it is. This not only is really important when determining things like allergic reactions, but also there are certain medical conditions like respiratory problems that build up over time. So this started 5 days ago. Okay, we'll kind of try and figure out around what time 5 days ago it was, as opposed to like, no, it hit right now, 20 minutes ago or 5 minutes ago. The other thing is strokes. Strokes is really big, which is why I put in the last known well time here. Getting the last known well time on strokes, incredibly important, because there are certain medications that you cannot give if it's outside of that time window. So we need to know what the last known well time is. And it's a specific like 6:52 or whatever it is. Problem here is if you have patients that wake up from like from the night, they wake up in the morning and they've got signs and symptoms of chest pain or stroke or whatever it is, whenever they knew they were good last. So if they were perfectly fine when they went to bed, that's their last known well. If they woke up at 2 o'clock in the morning and were still completely fine, went to the bathroom, went to bed, that was their last known well. All right. Within our secondary assessment, we also want to include our vital signs, so our blood pressure, pulse, SpO2, skin condition, respiratory rate, pupils, temperature, and blood sugar. And then that wraps up our secondary assessment. So that was all for the lectures for this week. So a lot of stuff that goes into this. I know my actual lecture time wasn't that long, but a lot of stuff in these chapters that's incredibly important. I think I mentioned this in the previous video, but the sooner you understand and kind of just flat out memorize this, the easier it is to start diving a little bit deeper into why we're looking at these things, and putting together a really good assessment. As always, feel free to message me, email me, call me, whatever you need to do to ask any questions. Yeah, see you next week.